Hello. Good afternoon. I'm Dr. Rossana Ditangco, one of the co-chair for this session, and welcome to the 6th plenary session on the long-term consequences of HIV infection and chronic antiretroviral therapy, or ART, or ART. ART has reduced HIV-related morbidity and mortality, and its impact on perinatal and behavior-related transmission has led to the recommendation on early testing and treatment. Although HIV suppression with ART may decrease inflammation and immune activation, thought to contribute to higher rates of cardiovascular and end organ damage reported in HIV-infected cohort, the overall levels of inflammation and immune activation are still higher in ART users than in HIV-negative individuals. Thus, the continuous threat of residual comorbidities among patients on highly effective therapy warrants continuous investigation on pathogenesis and beyond ART intervention, and to revisit our definition of holistic HIV care. The plenary session will have the following objectives. First, to provide a brief overview of the pathophysiologic mechanisms of chronic immune activation, to discuss the clinical consequences of chronic immune activation and the implication for PLHIVs, and to discuss the role of holistic primary care of PLHIV patients and to ensure that the effects of chronic immune activation are identified early and mitigated appropriately. May I now call on the co-chair of this session, Dr. Karl Henson, to introduce our distinguished plenary speaker.
Thank you, Dr. Ditangco. So our speaker for this afternoon's plenary is an assistant professor. Can I have the slide? Is assistant professor at the Department of Family Medicine, University of Pittsburgh, and an assistant professor in the HIV/AIDS program of the Department of Infectious Diseases in the same university. And he is director of the HIV and Hep C program of UPMC McKeesport Family Medicine Residency Program and global health director of the same institution. On a personal note, he's a very good friend who has been coming to the Philippine General Hospital since I was a fellow there. He did a rotation with Dr. Salvania, and he's been coming back since that first time, 6 or 7 years ago. It is my honor and my pleasure to welcome to the stage Dr. Gordon Liu.
I'm getting my bearings straight. Now, I'm going to start my time now, okay? So as I'm speaking here, start, okay? So good afternoon, everyone. Wow, it's a big crowd today. Again, for those of you who came by to the earlier talk, I want to apologize. I am feeling a little under the weather. I promise you it's not TB, okay? I had my quantiferon checked recently, so I'll hopefully be holding up okay. I'm sorry you're stuck with me for the next half an hour. But when I was invited to do this talk, it was very humbling because, again, as Karl said, I've been coming here for a couple years, and this is a topic that's very passionate to myself. So I know my colleague had mentioned the objectives, and I just want to go over it briefly, that this will be a brief overview of chronic immune activation of patients living with HIV. We are going to be talking about a little bit the consequences of chronic immune activation and its implications for patients living with HIV, and really looking at the holistic primary care aspect of patients living with HIV to ensure that the chronic immune activation is identified early and mitigated appropriately. So, the first slide, this is the changing epidemiology. So HIV-infected adults have a higher risk of myocardial infarction, end-stage renal disease, and non-AIDS defining cancers, but they occur at similar ages than those without HIV. So if you take a look at some of these figures. So the first one, this looks at myocardial infarction. The little white dots are individuals who are HIV negative, and the black dots are individuals who are HIV positive. And you see that there is a statistically significant difference in the number of cases of myocardial infarction with patients living with HIV. And this could be a higher incidence of greater progression of high-risk plaques that develop in patients who are HIV positive versus those who are HIV negative. The same theory also applies to patients with end-stage renal disease. You see that there is a significant gap, and also non-AIDS defining malignancies. So that's really important for us to point out. And as I'm going through this and make sure everything's good, sorry. There we go. So this is believed to be secondary to high levels of inflammation and immune activation observed in patients living with HIV despite, so I think that's a key word there, despite being virally suppressed. So if you take a look at this slide, this is the HIV persistence and chronic inflammation, and I want you to take a look at the graph. So the first line is the plasma viral load. That is looking at what the viral load is when somebody is first diagnosed with HIV. And then at ART initiation, the viral load will slowly come down and become undetectable. The line below that is the line of inflammation. That is patients living with HIV. That is the line of inflammation. And then below that is patients who are HIV negative. So why is there a gap? Why is there a gap between negative patients versus positive patients? So there are a couple of studies that took a look at this and looked at individual markers on why this is occurring. So the first one on the top right, that study looked at soluble CD14, and it found that it was independently associated with coronary calcification. So we know patients living with HIV, even with a suppressed viral load, have a higher level of CD14. The second study, this was looking at elevated biomarkers. So this was looking at IL-6, looking at CD14, and all of this was also higher in patients that were HIV positive with a suppressed viral load. The next one is a group by a UCSF. Priscilla Sue is a cardiologist out at UCSF that looked at levels of IL-6, which were elevated in patients living with HIV, and that increases, that sole marker, there's an increased risk for atherosclerosis. And then the next one is a little bit closer to home for me. Dr. Bernard Makatangai, who is the big researcher at the University of Pittsburgh, him and a group looked at inflammatory biomarkers. So that was IL-2 alpha, IL-6, CD14 markers that were actually elevated and showed mortality risk among HIV-suppressed men. And the last one was a study that showed plasma-soluble CD163, and these levels were elevated and were independently predicting all-cause mortality in patients living with HIV. So inflammation and chronic HIV, when an individual is virally suppressed, why is there continued inflammation? Why is there this chronic, in the long term, all this inflammation that's occurring? So there's a lot of hypotheses that we've seen, but there's not one that we can say this is exactly the reason why that there's chronic inflammation. So the first one we can take a look is viral replication and persistent viremia. Is it true, that there is increasing viral replication in tissues even if someone is virally suppressed, and that there is still low-level viremia? So we actually know that's true. So if you guys check a viral load on one of your patients and it ends up being undetectable, but how many times have you seen maybe in 3 or 4 months, sometimes they spew a little bit of viral load, like maybe 61 or 150? That's a viral blip. So that can kind of help us justify that persistent viremia type of theory. The next one is microbial translocation and dysbiosis. This specifically looks, over the last couple years, we've been doing a lot of research on the gut genome. So looking at the gut genome, we know that everybody's gut genome is different. And a lot of studies are looking at the gut genome of someone who is HIV positive versus someone who is HIV negative. So in an individual living with HIV, we know that there is bacteria that promotes inflammation in the gut, and it overwhelms the bacteria that actually helps with chronic health. So what happens when somebody is newly diagnosed? We have this inflammation, and it affects the gut, there's some dysfunction, and then when they start treatment, there's actually not a complete recovery. And then you get what we call a leaky gut, which is when you have chronic inflammation that's spilling in the gut. The next one is co-infection with the herpes virus. We know that individuals living with HIV that have co-infection with the HSV virus, there is subclinical increase in shedding in these patients. Also, lymphatic fibrosis. So this is very similar to the microbial translocation dysbiosis. So when somebody is first positive with HIV, you see an increase in activation of their lymphatic system. So you get lymphatic fibrosis. And then when they're under treatment, it doesn't recover in time. So that's how you get the chronic inflammation. And then lastly, we have inadequate immunoregulation. So what that means is that we know for a fact that a little bit of inflammation in our body, the response is good. But too much of chronic inflammation is not good. And so we have an arm in our immune system that actually balances that, so that it balances the chronic inflammation. But when you have persistence, there's going to be some kind of dysfunction, and that imbalance is causing the chronic inflammation. So there are a lot of ongoing, completed, and upcoming studies. A couple of them looked at low dose, to say, for example, the C's are the completed ones. Low dose methotrexate or isoretinoin to decrease inflammation. These studies are being written up, the results. The preliminary results are not that promising, but it's something that we're looking at. The ongoing ones, two of them that really sit into my mind is the sitagliptin, Januvia, to reduce inflammation, and then the REPRIEVE study. So how many of you guys have heard of the REPRIEVE study? Anybody? Okay. So the REPRIEVE study is a multinational study. This is looking at the use of pitavastatin to prevent vascular event. So they're looking at individuals who are HIV positive. They calculate their ASCVD risk score. And if the ASCVD risk score is below 7.5%, they will either put them into a placebo group or they put them on pitavastatin, and to see if there's actually a reduction in inflammation. So I think we're at the last stages. How I know a lot about this study is because my colleague who's the head of this study at our site is always up my butt and trying to text me, did you ask this patient to see if they qualify? Well, I'm like, yes, I did. And so that's why she's always on my case. That's how I know about it that much. So how does this change the way we manage patients living with HIV? That's the big question. We know for a fact that there is chronic inflammation. And this chronic inflammation, if our patients are living older, it's gonna be unopposed. And they're gonna develop non-AIDS defining malignancies, end-stage renal disease, cardiovascular disease. This is why we need to be prepared to be able to manage those chronic medical conditions as we see them. So this is a very fun question. If those of you at my talk this morning, apparently there was crickets, because it seems like everybody was a little shy to put up their hands. I would like a little bit more participation. So what is the age of the oldest patient you have in your practice? Karl, I'm gonna pick a 64? 64, that's pretty impressive. 81, I think she wins. I'm gonna buy you a cup of coffee after, okay? Buy coffee, okay, yeah. Karl? 60. So the oldest patient at our Pittsburgh AIDS Center for Treatment is 89. She's been positive for 35 years, has been on antiretrovirals. Her CD4 count is in the 400s, and her viral load is suppressed, but she has a lot of chronic medical problems, and that's where we're gonna address today. So looking at the epidemic and looking at new models of HIV care, this is so important because, you know, in the Western countries, we've had this care model where in the 80s, there was the opportunistic infection era, which is basically a death sentence. When you were diagnosed with HIV at this point, you basically was just waiting to die. It was palliative care. A lot of the specialists were palliative care doctors. And it was really treatment of OIs. Have any of you guys seen the movie Dallas Buyers Club? Anybody? Yeah. Okay. That is actually one of my favorite movies. And when my parents asked me, who are here today, what do you do for a living? And I said, just watch the movie. And maybe you can have an idea of what I do. And so that movie really talks about the AZT era. The antiretroviral era was in the 90s. That was really focused on the HIV specialist, the focus on viral pathogenesis, and that was when triple therapy was applied. That was in the 90s. And that was, back home in Canada, the Vancouver conference. But now we are in this chronic disease era, which is HIV disease management and primary care. So if you ask any of my residents or colleagues who practice HIV care back home, how many % is actually HIV care? What do you think they will say? Karl says 30. It's actually closer to 20%. The other 80% is actually primary care. And so this is why this model is moving that way, because there are actually a lot of ID physicians in the US, in Canada, in the UK that don't practice HIV care because it's always changing, and there's that huge aspect of primary care. So chronic HIV care, we know that HIV is a chronic disease. There is an increased life expectancy. If you look at the Athena trial, we know that for recently diagnosed and asymptomatic patients, that the life expectancy is relatively the same as someone without HIV. And the CDC in 2017 posted that 50% of patients living with HIV are actually over 50 years old. And the causes of death, if you look at the DAD study, the cohort, that the number one cause of death was non-AIDS defining malignancies. So it wasn't AIDS, it was non-AIDS defining malignancies, it was cancers. And then the second was cardiovascular disease, which is about 20%. So if you have a big proportion of your patients that are dying not from AIDS complications, but from chronic illnesses, we need to be a little bit more familiar with how to manage and prevent these illnesses. So I'm a little biased being a primary care provider. This is a self-reported level of comfort with prescribing treatment for, I saw that 15 minutes, I have 17, I'm just going by the time, okay? Comfort with prescribing of hyperlipidemia, diabetes, hypertension, and depression. And if you take a look at this, the dark bars are general medicine, which is internal medicine and family medicine, and the white bars is infectious disease specialists. And looking at the comfort of them managing hyperlipidemia, but look at the difference in depression. That is roughly about 80% to 35%. That is a huge difference. And so we know a lot of our patients that are living with HIV actually have a lot of mental health issues that we need to address. So why is it important to provide comprehensive primary care in patients living without HIV? So number one is we know that the life expectancy in these patients are similar to that of persons living without HIV, and they will inevitably develop all these chronic medical conditions. So think about your grandmother or your mother, the medical problems that they have, diabetes, hypertension. These are all things that patients will develop. And this is based on North American data, but more than 50% of patients living with HIV also have a psychiatric condition. So PTSD, schizophrenia, depression, anxiety. So it's that much more important for you to understand and learn how to manage these patients. So why is it important? Because it really does reduce barriers. We're minimizing off-site medical appointments. So when a patient comes to see me, they're able to get a lot of their chronic care, whether it's with their primary care, orthopedics, derm, their HIV care, all is under one place. And by doing this, it minimizes the number of referrals and where the patient's going. So if you think about it, it actually applies a little bit more here, right? A lot of your patients might come to your clinic, maybe it takes an hour or 2 hours by bus, by jeepney, by tricycle, and then they have to do that every time they go see a specialist. So by reducing that barrier to care, you may be able to help the patient not only with compliance with their medical appointments, but also with their antiretrovirals. We need to educate and to reduce the stigma that we have, and it's not just stigma here, it's stigma everywhere. And it's not only educating our patients and their families, but healthcare providers and also the community. And then to provide culturally competent care and to advocate for necessary resources. So just to tell you a little bit about back home, the Pittsburgh AIDS Center for Treatment, the PACT clinic, was one of the first 10 HIV clinics in the country. It's a patient-centered model of HIV primary care with 1,700 patients. So in the clinic, there are 10 providers, 8 ID physicians, 1 family physician, that's me, and 1 physician assistant. But all of us, we do provide specialty HIV care and primary care. So all my ID colleagues that are doing this also do hypertension, diabetes, depression. We're there about 9 half-day sessions per week. We have consultative services in the hospital. And I can't stress enough the weekly multidisciplinary case conferences. At our clinic, we have no egos. Everybody treats each other the same. So we bring up difficult cases and we discuss them, whether it's a crazy genotype question, or it could be a patient comes 2.5 hours, how are we going to reduce these barriers? So these are all multidisciplinary case conferences. We have on-site subspecialty care, which is like anal dysplasia, gyne, musculoskeletal. I do all the joint injections at our clinic, addiction, pain. And then we're also a major training site for ID fellows, primary care residents, and medical students. So one of the things is I'm also a director of the Family Medicine Primary Care HIV track. This is one of 9 tracks that graduate an HIV specialist out of the program, that they graduate from family medicine into becoming an HIV specialist. Now, I'm not trying to throw her on the spot today, but Ali Vogel is here with me today. Just wave, Ali. Thank you. She is my second-year family medicine resident that's in the HIV track. And after 2 years, she's going to graduate to be an HIV specialist. And so we have a lot of training there to move towards this primary care model. So some of the key concepts in the management of those living with chronic HIV, the biggest one we have to look at is cancer screenings, because that is the #1 cause of death in patients living with HIV. So the first one is colorectal cancer screening, right? These are guidelines for those without HIV, and that was starting at the age of 50 and then continuing to the age of 75. We either recommend a sigmoidoscopy, a colonoscopy, or a FIT test. Now, for those of you who don't know what a FIT test is, that's a fecal immunochemistry test. So you basically have a bowel movement, you take a little sample, you put it on a card, and you send it in. And if the lab detects that there is any blood, then they recommend a colonoscopy. If it's negative, then you repeat it next year. And these same guidelines apply to patients living with HIV. Breast cancer screening, so we go by the American College of Obstetrics and Gynecology. These are the same recommendations in the UK, Canada, and Australia. So women at the age of 40 are offered screening mammograms. And if they choose not to, though, they should have their first mammogram no later than 50. But this is a shared decision-making that they're having. And this also applies with patients living with HIV. Our cervical cancer screening, so we know cervical dysplasia is higher in patients living with HIV. So with women ages less than 30, they will have 1 pap smear following initial diagnosis, and it should be repeated every 12 months. After the first 3 are negative, then it can be spaced out every 3 years. But they don't recommend pap testing with HPV because there was no evidence that it was going to change any of our outcomes. Now, if somebody is younger than 21, then 1 year after initiation of sexual activity, then they should have a pap smear, and this is a grade B evidence. And then women who are age 30 or over, they recommend pap testing with HPV, co-testing at baseline, and if it's negative, go ahead and repeat every 3 years. One of the last ones I want to talk about is anal dysplasia. So we know that anal dysplasia is very, very prevalent in our MSM population. So MSM, any patient with a history of anal genital condylomas, and women with abnormal cervical and or vulvar histology. So they recommend anal cytology at baseline and annually in the stated populations with HIV. So the only other one I didn't put up there was actually lung cancer screening. We actually see a lot of cases of lung cancer, but the screening guidelines that we have actually doesn't have a lot of evidence. They recommend that they do a low-dose CT scan between the ages of 55 to 80, but the number needed to treat is actually a very poor number. But smoking cessation counseling is very important and probably a good idea to do during your office visits. Cardiovascular health is the second one. And that's really important because of the fact that we know that our patients are affected when it comes to cardiovascular health. So we use the ATP IV Guidelines. I know some of you know that about 2.5 weeks ago, the ATP V Guidelines just came out. Now, the American Academy of HIV Medicine hasn't adopted these guidelines yet, so I'm going to stick with the old ones. So making sure that if the patient has a history of heart disease, peripheral vascular disease, and stroke, to go ahead and start on a high-intensity statin. If their LDL is greater than 190 milligrams per deciliter, then a high-intensity statin as well. If your patients have diabetes and they're between 40 to 75 and have an LDL between 70 to 189, they should be started on a moderate-intensity statin. And then lastly, if their ASCVD risk score is above 7.5%, then they recommend that to start a statin. And any combination of 3 and 4 should be on a high intensity. So primary prevention data is not that great. But we know that no cardiovascular calculators include HIV. And we know HIV is a chronic inflammatory disease. So we're a little bit more liberal when it comes to starting a patient on a statin. Chronic ART effects. So we talked a little bit about this morning. I'm not going to go too in depth with this. A couple of the medications like abacavir, be careful of the hypersensitivity and the cardiovascular events. This is more in European models and also animal models. Zidovudine, make sure you're checking your CBC. A lot of anemia. You get also avascular necrosis and peripheral neuropathy. TDF, tenofovir disoproxil. Kidney function, checking your BMP and urine analysis every 6 months. And bone health, which is checking a DEXA scan at the age of 50 and over. Nevirapine, hepatotoxicity and rash. Efavirenz, dyslipidemia, CNS effects, and mental health. Please don't forget that our patients do have issues with mental health, so you can do something as simple as a PHQ-2. There's just basically 2 questions to assess at a baseline if your patient has any type of depression. And lastly, with lopinavir, ritonavir, we should probably remember to check their lipids and to look at cardiovascular health because it does prolong a lot of QTC and there's a higher risk for metabolic syndrome. The drug-drug interactions, as we talked about this morning with rifampin, are pretty big issues that we have here, and that's something that should be addressed. And hopefully with dolutegravir, approved by the WHO, I'm going to keep my fingers crossed that the Philippines will have that medication soon. Lastly, don't forget vaccinations. We want to keep our patients out of the hospital. That's the purpose of vaccines. I know that in the Philippines, there has been a lot of issues with vaccines, especially with the dengue vaccine. I'm not here to debate that at all. That's for a whole other session that does not involve me, okay? But your pneumonia vaccines, so your Prevnar and your Pneumovax, your meningitis vaccines, so your Menveo or your Menatra, tetanus, shingles. You guys know that there's a new shingles vaccine, the Shingrix. It's 12 times better than the Zostavax, that it was a live vaccine. And the age difference is shingles, you can give it at the age of 50 and over versus 60 from the live vaccine. Hepatitis A and B, HPV, you remember now that patients can be older than 26 to have the vaccine. 45, thank you, Karl. And influenza, I know we have different strains of influenza, so definitely get your flu shots. So lastly, I love this quote, because who is an HIV specialist? HIV disease does not fall under any one medical specialty. Physicians trained in internal medicine, family medicine, and other medical subspecialties join infectious disease specialists and HIV experts. And this was published by the IDSA. So before I finish, excuse me, I do want to thank a couple people. Bernard Makatengai is one of my colleagues back home, and Deb McMahon, who runs our clinic, who's always been supportive of my career. Dr. Alejandria, I want to thank you for the invitation and always for supporting me while I spend my time here over the last couple years. Dr. Silvana for teaching our residents and really having that educational background for backup. My good friend Karl Henson was my first Filipino medical friend when I was here in the Philippines, and I really do appreciate your friendship. And Rose, if she's here, I don't know how you do it. You put up with so much with me for me coming here, so I wanted to say thank you. And lastly, my family, my parents, and my wife, who came all the way from back home to come support me. I really appreciate it. Thank you.
Dr. Liu, may I request you to remain on the
Yes, of
stage
course,
for
yeah.
the awarding of the Certificate of Appreciation? May I call on Dr. Alejandria, is she here, to join us?
This will be familiar to you now. The citation, or the Certificate of Appreciation reads, we give this Certificate of Appreciation to Dr. Gordon Liu for sharing his invaluable insights and inspiring words of wisdom as plenary speaker on the topic long-term consequences of HIV infection and chronic ART, thereby contributing to the continuing medical education of this society on the occasion of the 40th PSMID Annual Convention. Signed, Dr. Rosario, the chair of the scientific committee, Dr. Alejandria, the vice president and overall chair of the convention, and Dr. Panaligan, PSMID president.
So good afternoon. I'm Dr. Jod Lim, and I'll be your co-chair. Our chair this afternoon is Dr. Jenny Chua. Unfortunately, she's a little sick, so she requested me to just do the duties for this afternoon. We'll be shifting gears towards a most important disease entity, which I suppose everyone encounters every now and then. And if you look at your census in the hospital, you know that there are a lot of mortalities coming from sepsis and septic shock. So this afternoon we have invited a speaker who is quite known to a lot of you already. So let me introduce to you our speaker for this afternoon. He's a clinical associate professor at the University of the Philippines, Manila. He's the chair of the Sepsis Guidelines Committee of the PSMID, chair of the Anogenital Ward Subcommittee of the PSMID. He co-chairs subcommittee on STIs. He's a research committee member, Department of Medicine, UPPGH, a task force member of the Pandemic Influenza and Emerging Disease Emergency Response at Makati Medical Center, an ID specialist at Asian Hospital, Makati Medical Center, Medical Doctors, and the Philippine General Hospital. He's one of the newest faculty of the UPPGH, and we know him as one faculty is fun to be with. So during his lecture, just watch out for the jokes he will probably drop. So this afternoon, let's welcome John D. Buensalido.
Good afternoon, everyone. I'll be presenting Sepsis, the Choice of the New Generation. Nauuhaw na ba tayong lahat? So I have no disclosures related to this talk, and these are my hospital affiliations. So basically, the outline, I'll be talking about definitions, clinical criteria, the sepsis bundle, phases of sepsis, and other controversial topics on sepsis. So first question, this is a 28-year-old female with a chief complaint of fever. She has been having 2 days of cough, colds, body aches, and fever. She's awake, conversant, with BP 110/70, tachycardic, tachypnic, febrile, and with a white blood cell count of 4,000 with lymphocytic predominance. Is this sepsis? How about this 28-year-old female with the chief complaint of dyspnea, 2 days of cough, pleuritic chest pain, and like we said, dyspnea, awake and conversant again, BP 120/80 with a heart rate that is tachycardic, tachypnic, febrile with crackles, and white blood cell count of 13,000, segmental predominance with an X-ray showing right lower lobe pneumonia. Is this sepsis? So this is a US textbook, Clinical Infectious Diseases, for which I was fortunate to have authored the chapter 2 on sepsis, severe sepsis, and septic shock. That was in 2015. It's now 2018, and it's considered old now, okay? So we wrote there that the systemic inflammatory response syndrome consists of temperature of 38 and above, 36 or below, heart rate above 90, respiratory rate above 20, white cells of 12,000 and above, or 4,000 and below. And the sepsis definition then was at least 2 SIRS criteria and infection. The old severe sepsis was sepsis that was complicated by organ dysfunction, hypotension, or signs of hypoperfusion. We know all these very well, no? Including septic shock, which was sepsis with acute circulatory failure that required pressor therapy after adequate fluid resuscitation. But is this really the definition of sepsis now? We know, and we shall see later on the evidence, that it is sensitive, but maybe too sensitive, and not very specific. And the truth is, this definition does not tell us what sepsis really is. The definition of definition is that it describes the essential nature of the condition or the thing that's being defined. So to tell you the truth,
does this really define sepsis? When I talk to residents and ID fellows, I always ask them when I speak about this, what is the definition of MI? And some will say, sir, chest pain, hypertroponinemia, and with or without ECG changes. No? And I would tell them, no, that's clinical criteria. This is the definition of MI. It's simple, heart muscle death with coronary, because of a coronary artery occlusion. No? So in that light, no, the previous SIRS criteria with infection was actually just clinical criteria during that time. This is the new definition of sepsis after the Sepsis 3 panel and task force went ahead and convened and made a consensus. So, and I agree with this, no? There are 4 components now. It should be first, life-threatening. Sepsis should be life-threatening. There should be organ dysfunction. And it's usually because of a dysregulated immune response to infection as the main cause. No? So para matandaan nating lahat, no, I made a mnemonic called LODI. No? Okay. So Gordon, that's idol spelled backward. Okay. Napanapanahon nakakapanahon tong si Lodi ngayon eh. So the truth is, sepsis now, as defined, is the old severe sepsis. Because really, SIRS plus infection may really just be a normal response to infection. Remember the first case, that was a influenza case that was not septic, but had almost all the SIRS criteria, but it was not septic in a 28-year-old. So how did they come about this new sepsis definition? Okay, so there was a subgroup of that panel, and that was Seymour et al. And this is what they thought of, though. So they came from the sepsis definition, and from the definition, they thought, who are the septic ones, no? Among the infected patients or patients with infection, those who are really sick, those are the ones who are septic. So sepsis, or the really sick population, became the proxy of sepsis, no? Especially since there's no gold standard. No? And how did they define really sick? No? Primarily, if there was high mortality, or if there was a prolonged stay in the hospital or ICU. So they looked at 21 variables from sepsis 2. They focused on timeliness and ease of use of possible variables, and they did multivariable logistic regression for in-hospital mortality. So they came up with the following, no? Respiratory rate of 22 and above, altered mental status, a systolic blood pressure of 100 and below. If someone meets 2 of the criteria, they would say that's positive for the quick SOFA. That means Q-SOFA is quick SOFA. So that tells us, no, if it's 2 and above, there's an increased risk of poorer outcomes. No? So they tested Q-SOFA against the more traditional SOFA and LOD score, or sequential organ failure assessment, and the logistic organ dysfunction scoring that's usually used by other centers or ICUs. Compared to when in the ICU, Q-SOFA is not as good as SOFA and LODs. But if you look at the right graph, no, or chart, no, you see that Q-SOFA is actually equivalent when it's used outside of the ICU, and that's good for us, no, because we can use it without necessary labs, no. And this is the SOFA score. It's easy to download. No, we can get it anywhere. But essentially, the SOFA score is what we use in the ICU, looking for organ dysfunction, whether neurologic, respiratory, cardiovascular, renal, hematologic, or liver. So why use SOFA for sepsis clinical criteria? Because it's familiar, it's easy to use, no? But most of all, because SOFA relates to a 10% chance of dying in the hospital if there's 2 or more, no? And usually, that's the mortality rate, the minimum mortality rate of sepsis, 10% to around 25%. And why a change of 2 from baseline SOFA? Because some people, especially those people with chronic illnesses, may have already a number of SOFA scores at baseline. But if we don't know and that patient only presents to us and says that he was previously healthy, then a SOFA score of 0 can be assigned to him or her. So now these are the clinical criteria that we can use. No? Infection plus 2 or more SOFA points above the baseline can be used in the ICU, or Q-SOFA of 2 or above plus infection may be a prompt outside the ICU to consider sepsis. But again, these are just tools, no? We shouldn't be too rigid, no? We should remember the definition, we should remember that these are tools, but treat the patient first and foremost. So, septic shock also has a new definition. It's a subset of sepsis in which underlying circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. And based on that definition, no, they modified the clinical criteria. Instead of just a low blood pressure that is unresponsive to fluids, they also added the cellular and metabolic abnormalities part. And that's where lactic acid or lactate comes in. Okay. And here we see that there is indeed high mortality in someone who has low blood pressure and a high lactate, and even goes up to 42.3%. So that is, in general, no, the mortality rate that we usually assign to septic shock. So how is, and this question was answered by one of our ID fellows, no, Dr. Sebar Sala. Among patients seen at the ER with a suspected infection, how accurate is Q-SOFA compared to SIRS in predicting mortality? No? So he went ahead and said that yes, this article was direct, was valid, was applicable, and let's just go straight to the results. No? If you look at the first red line on top, no, that's the overall sensitivity of Q-SOFA, no? 60%, no? Not so good, no? But SIRS definitely has very good sensitivity at 88%. But if you look at specificity, Q-SOFA has 72%, while SIRS has a measly 25%. No? So SIRS is pretty good with sensitivity, but poor in specificity. And if we look at the more useful ratios or tools clinically, that's likelihood ratios. No? Positive likelihood ratio, it's 2 for Q-SOFA and 1.1 for SIRS. No? So in this, in likelihood ratios, when it's positive likelihood ratio, Q-SOFA is superior to SIRS. While negative likelihood ratio, Q-SOFA has 0.5, while SIRS has 0.4, so not that much different. No? So if we summarize those slides, no? SIRS is very sensitive, okay, but poorly specific. Q-SOFA, on the other hand, is superior in terms of specificity for infection-related mortality, which is the sepsis proxy. In terms of positive likelihood ratio, it's Q-SOFA that is superior, while negative likelihood ratio of both are equivalent. And therefore, clinically, Q-SOFA may be more useful than SIRS in diagnosing true sepsis. So do we say goodbye to SIRS in this case? No? I agree when people say, if people are unwilling to let go of using the SIRS criteria, when they say, I don't want to miss septic cases, no? I don't want to diagnose them when they're already life-threatening. And yes, if SIRS is pretty good in terms of sensitivity, I think let's go use it, okay? I think the new role, and this is my proposal, to continue to use SIRS, no, for screening, because that's the strength of SIRS, but it might need confirmation to diagnose true sepsis, such as adding SOFA or Q-SOFA. Why? Because having a too sensitive test ends up with too many false positives. No? And therefore, if there are a lot of false positives, maybe the term should be potentially septic. For example, a resident calls me and I ask, is the patient septic? Yes, sir. Then I have to ask, is it based on SIRS? If it's yes, no, maybe I should tell, baka hindi pa talaga septic yan. No? So it's possible, but let's watch. No? But it's not like if we label someone potentially septic because of SIRS positive characteristics, we don't do anything. No? If someone is labeled potentially septic, we still work up the patient. We still give the antibiotic based on the infection and monitor for sepsis development. But for those that we can really accurately label as septic or septic shock, then we start the sepsis bundle or whatever is in your institution's pathway, okay? But at least by using these two terms, we are able to remove false positivity and prevent over-diagnosis and over-resuscitating falsely positive septic patients. No? So the old sepsis bundles that we mentioned in our chapter was this. No? There used to be a 3-hour and 6-hour bundle, including antibiotics, blood cultures before antibiotics, crystalloids for hypotension or hyperlactatemia, and of course lactate. But just this year, the Surviving Sepsis campaign changed this and made the 3- and 6-hour bundles just a 1-hour bundle. So it's now simpler, but there is, of course, the guys who made the 1-hour bundle say there is compelling evidence to do this because there is improved survival when you use the bundles. No? And it reflects clinical reality at the bedside, they said. Because it should be, especially if someone has hypotension, let's start the bundles, get it running, no? But there was negative backlash, okay? The guys who said, no, we don't like this 1-hour bundle, said that the quality of evidence for the bundle elements was, was low to moderate. And there was high quality evidence, according to them, that this increases utilization of resources without actually benefiting most patients. No? Plus, in the Western world, no, like for example in the US, there would be penalties, no, if someone is unable to perform the mandated 1-hour bundle. No? Lastly, adherence to the bundle, they thought, would actually might harm some populations like CHF patients, no, or anuric CKD stage 5 patients. No? Especially since included in the bundle is this recommendation that at least 30 ml per kilo of IV crystalloid fluid should be given within the first 3 hours with reassessment afterwards. No? But if that is the recommendation and it's enforced by government, no, that will be difficult. No? So let's take a look at fluid resuscitation now. No? Now this is a good study showing that fluid resuscitation should actually be done within the first 30 minutes. No? It's common sense, but at least there's data to support the common sense. No? Here we see mortality is improved, length of stay is improved if fluid resuscitation is started within 30 minutes. No? And look at the graph. No? There's a linear line showing that there's an increase in hazard, increase in length of stay, the longer it takes for fluid resuscitation to start. And this meta-analysis concluded that among patients with sepsis, resuscitation with balanced crystalloids or albumin compared with other fluids seemed to be associated with reduced mortality. No? The guidelines for the Surviving Sepsis campaign, no, tell us that crystalloids should be first line, but the type of crystalloid is not actually specified. Although there is increasing evidence that normal saline is associated with increased mortality and kidney injury, and therefore balanced crystalloids may be safer as an alternative. No? And then albumin, same outcomes, but more costly, so becomes second line. Okay. And this other meta-analysis did not demonstrate any significant advantage as well with albumin, and therefore crystalloids remain as the first choice for fluid resuscitation. Now, what was the one that was specified in the guidelines saying we should not be using this particular fluid, no, for fluid resuscitation in septic patients? That's HES, or hydroxyethyl starch. No? otherwise known as Voluven here in the Philippines. No? If you look at the electrolytes, sodium is 154, chloride is 154. Okay? If you look at saline, or normal saline, sodium is 154 and chloride is 154, far and away from the normal, which is 135 to 145 for sodium and around 100 to 110 for chloride. If you look at lactated ringers, or LR, no, sodium is 130, chloride is 109, closer to what's normal. So actually, normal saline might not actually be normal saline, no? Because LR is actually closer to normal. Okay, so saline may cause hyperchloremic acidosis, and it's dose-dependent. Sepsis, we need to give lots of fluids, so the risk is higher, okay? Unlike balanced solutions. No? Also, saline reduces splanchnic bed and renal perfusion, reducing urine excretion and increasing nausea and vomiting. No? So in my practice, no, I actually use more of LR these days. No? Okay. Now let's go to mortality, no, in regard to liberal fluid administration in sepsis. No. These are a couple of studies. I won't go through them one by one, but the only thing that it's trying to say is that a positive balance, no, on day 1 or 12 hours or 72 hours has been associated with increasing mortality, no, which tells us that we should be wary and be careful with regard to total volume of fluids, no, especially in patients with sepsis. No. So, we remember rivers, no? And those were the ones on the top are actually the older trials. The newer trials are the PROMISE and the ARISE. No? Rivers studies would be, they usually gave fluids of around 4.5 liters to 5,000. While the newer studies give around 2,000 of fluids in the first 6 hours. And you see, of course, CVP will be higher, no? Those who give more fluids. No? But mortality-wise, fluids in the first 72 hours, no? This is mortality, and the number of liters is on the right side. If you look at the ARISE and PROMISE, they have less fluids, they provide less fluids, and they have less mortality compared to the Rivers and Janssen trials. Higher fluids given in 72 hours, but also higher mortality. And this is an easier way to look at it. No? On day 1, you see that there is an increase of mortality, no? Hospital mortality, after you reach more than 5 liters of fluid on day 1. So one thing that you usually forget, no, we used to do this as interns, no, but reassessment, no, after giving fluids, it's very important to go back to the basics of reassessment, no. And the guidelines tell us that we should be using dynamic variables over static variables. Okay? And then these are the static variables: CVP, BNP, all the rest. But that's not recommended. What's recommended are the dynamic variables such as pulse pressure variation, stroke volume variation, and the IVC or SVC diameter change using echo. No? But that's too much to do. No? That will require a Swan-Ganz, an A-line, no? And an echo. No? The cheaper options would be to give a 500 ml fluid challenge, no? And the passive leg raise. No? This is the example of using a Swan-Ganz, no, to show and calculate cardiac output there, 5, and stroke volume at 53. And here on the lower left side are the normal hemodynamics. A patient, no, will be labeled fluid responsive if there's a 10 to 15 increase in stroke volume or cardiac output. Pero paano tayo? Wala tayong Swan-Ganz usually, no? Ito, when they gave the 1,000 ml of fluid, nag-increase yung cardiac output and stroke volume by 15%. No? So we always forget yung passive leg raise. No? This is a way of testing for fluid responsiveness without infusing anything. Okay? So we should, that's a good way, no? Especially in our CHF patients, although baka mahirapan sila saglit sa paghinga when we do that. So one thing that I came upon was this Wind-Kessel formula. It's a non-invasive technique. It's cheaper, easier to implement because you just need the pulse pressure, the heart rate, and to multiply it to 0.002. And allegedly there was good agreement with cardiac output. No? So maybe one thing to explore in the future. No? So the 6-hour bundle, we said is gone. No? And even the CVP, we don't use CVP for fluid reassessment anymore. No? Now, this concept of conservative fluid management or de-resuscitation is pretty interesting. No? And it's mostly green and yellow, so in general, there's lower risk of bias. No? Okay, but let's look at this outcome. No? When physicians do this type of strategy, there seem to be less ventilator, there are more ventilator-free days, no? And there is also length of stay decrease, okay? So what are they trying to tell us, no? I'll just go straight here. So if we look at this mortality chart again, no, it seems that if there is late liberal strategy of fluid administration, there seems to be higher mortality. No? And then it doesn't matter whether it's early adequate or early conservative, but it looks like the driver for mortality is using a late liberal fluid strategy. So this is just one example of one way to do it would be to give an initial resuscitation of 500 ml bolus of crystalloid up to a maximum of 20 ml and determine fluid responsiveness with what we've talked about. No? So that is one example. And this is in general the new concept called, in this case, the SOS de-escalation concept, giving empirical bolus of fluid in the first couple of minutes, optimizing and titrating fluids in the next hours, stabilizing and minimizing infusion in the next couple of days, and de-escalation or de-resuscitation, aiming for negative fluid balance in the next days to weeks while the patient is admitted. It's also called the ROSE concept to avoid fluid overload. So, the multi-phase nature of sepsis, no? In the early phase, we know, and it's also called the EB phase, there's a relative hypovolemia. And stroke volume and cardiac output are decreased, and therefore fluids help. But in the late phase, wherein the patient is hyperdynamic, stroke volume and cardiac output are normal or increased, okay? And there is also microcapillary obstruction from clot obstruction and cell debris, and therefore at this stage, fluids are unlikely to help. No? So this is just an illustration showing that at this stage, fluids are unlikely to help. No? And Dr. Alejandria, Karl, and I, and a couple other ID physicians are involved in this trial called the HALO International Phase 2 RCT, wherein it's trying to see whether IV unfractionated heparin will help, no, in septic shock. No? In general, it's just trying to act on that phase of sepsis wherein there is a lot of coagulation. No? It's scary, but you know, if it's under the trial, it's worth a shot, especially if there are potential benefits. No? How about procalcitonin? No? The guidelines say that procalcitonin can be used to support shortening duration of antibiotic therapy. And if we look at a couple of meta-analyses, such as this one, no, the diagnostic accuracy of procalcitonin for sepsis is around 0.85. That's the area under the receiver operating characteristic or curve. No? And the sensitivity is 0.8, specificity of 0.77, diagnostic odds ratio of 12.5. Of course, it's much better than CRP when we compare the two. No? But there's also evidence of this, such as this meta-analysis, showing that in procalcitonin-guided groups, no, mortality is significantly lower, no, and treatment duration is also less. No? Therefore, it's considered safer, and it also helps with decreasing antibiotic use. No? So last would be steroids. No? And this meta-analysis included 21 randomized controlled trials. And this was in 2009. No? The effect of steroids on mortality was considered highly variable based on this meta-analysis. But there was a difference. No? Early on, before 1989, the practice was to use high-dose steroids for short periods, no? And that increased mortality. While trials after 1997 used lower doses of steroids and a much longer course. And there's evidence that it consistently improved shock reversal and even heterogeneously benefits on mortality. No? But when they focused on hydrocortisone alone, no, this was a 2014 trial, no, there was no reduction in mortality, but the shock reversal was still there at 7 days and 28 days. Same goes for this 2015 meta-analysis, wherein there was no significant effect on mortality, okay, even when stratifying with regard to dose, whether high dose or low dose. But the good news here in this trial is no significant effects as well on serious adverse events. No? Now this 2015 steroid meta-analysis as well, in contrast to the latter two meta-analyses, showed some reduction of mortality, not the main one, but for in-hospital mortality and for long course and low dose steroids, but moderate quality of evidence. No? But what is always there and what is consistent is the shock reversal. No? Steroids hasten shock reversal in septic shock. No? Steroids also reduced SOFA score significantly, length of stay in the ICU, without increasing GI bleeding, superinfection, and neuromuscular weakness. However, steroids increased hyperglycemia and hypernatremia. And the most recent meta-analysis, again, no, showing inconsistency again, no benefit in mortality, but there's evidence of shock reversal again, no, which I would want my patient to, I would want to be able to reverse the shock of, in my patients as fast as I could. No? Now, I'm working with one of our fellows, no, Hani Jane Limos, no, and of course Dr. Isa as well. And we are trying to look at the prescribing patterns in the use of steroids in septic shock. No? And it's simple. No? We just want to know what the practice is of clinicians, no? In terms of usage of steroids, type, dose, method, and timing of initiation. No? But my focus, I think, would be timing. I think that's the key. No? Wala pang big trials, or there's some, no, but not as extensively studied as those. But timing may be the key. No? In your practice, no, do you start steroid when the patient is already on 3 pressors? Or do you start them when the patient is already on 2 pressors? Or do you start them when the patient is only on 1 pressor, but maximal doses already? Or do you start it when this patient is already on pressors and the dose is increasing? No? So, ano kayang maganda doon? No? Hindi natin alam. We might see, no? But the concept is like this, no? If a tree, let's say it's like septic shock, if it's already falling, no, is it easier to stop the septic shock when it's at this stage, or will it be easier to stop it at this stage? No, so we'll know. We'll update you when the results are out. But in summary, the new definition of sepsis is LODI. The SIRS criteria is highly sensitive, but maybe too sensitive for sepsis alone. QSOFA is superior to SIRS in identifying higher risk of mortality. SIRS can still be used, of course, and I think it should be used as a screening tool for potentially septic patients. No? QSOFA and SOFA are just tools. No? The 1R bundle is very controversial. The crystalloids are the first line for fluid resuscitation, but LR or balanced solutions might be better. No? Excessive fluid administration may lead to worse outcomes, and we discussed the phases of sepsis. Ebb phase, wherein it's likely to be fluid responsive, while the hyperdynamic phase, unlikely to be fluid responsive. Heparin in sepsis is presently being investigated, may be promising. Procalcitonin may aid in shortening antibiotic duration, although, costs may rise. No? And then low-dose steroid hastens shock reversal in septic shock, but mortality evidence was heterogeneous. No? And timing may be the key. We'll update you. So thank you for your attention. Catch tonight's premiere, showing of Sepsis is the Beast, a tale as old as time, but with an all-new and better cast, as you can see there. Thank you so much.
Okay, so in-announce Dr. Bon Salido, meron siyang special role mamaya doon, kaya abangan. So in behalf of the organizing committee, may I request my chair to just join me to present the certificate of appreciation to Dr. Bon Salido for giving us a topic. Isa, can you join us? So I suppose controversies in sepsis, so he has presented the controversies. I know that there will be more controversies, even as we do more studies. So Isa and Dr. Chua, can you present certificate of appreciation? Thank you very much, John Lee.
Business meeting will be at function room 3 here. Okay. So please proceed to function room 3 for our business meeting.